Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
In this week's episode, I sat down with my esteemed colleague, Dr. Artinder Nagra, who was my nerve fellow and just finished her nerve fellowship about a month or so ago. And we're talking about CRPS. Specifically, we talk about the role of neuroinflammation in the development of complex regional pain syndrome. I think you'll find this episode very interesting as we touch on some of the different tissue responses from the keratinocytes to the glial cells and how they play a big role with the immune system and all of these other complex biochemical pathways that play a role in not only the development of CRPS, but the maintenance of CRPS for patients. So please enjoy this conversation that I have with Dr. Artinder Nagra. All right. Well, good afternoon, Dr. Nagra. I think this is going to be a very special episode because you're no longer my nerve fellow, and you're now up in Pennsylvania getting ready to start your nerve practice up there, and I'm very excited for you. And I think we'll have some fun today and future explorations for sure. So thanks for coming out this afternoon.
Thank you. Yeah, this is the first time I'm not where you're at. So we're doing it from two different places.
Yeah.
And you don't get to say I'm doing a podcast with one of my favorite nerve fellows anymore.
Exactly. Right. So yeah.
Maybe I can be another favorite in something else now.
Yeah. Well, the question is, are you over the PTSD from serving the fellowship, or are we still have therapy to go?
PTSD. I had so much fun. It was great.
It was great. I enjoyed having you so much. And really, it doesn't end our collaboration for sure, because we've got a lot of fun projects. So I wanted to talk to you today about complex regional pain syndrome. It's something that everyone kind of just gets the willies when they hear it because it's so devastating for patients. And we're going to go over and review this article that just was pretty recently published in 2023 called The Role of Neuroinflammation in Complex Regional Pain Syndrome, a comprehensive review. And I think it's a great paper. I will post it on the show notes so that people can access it when we're done. But before we get into some of the molecular activity of the neuroinflammation, which I think this article is great, let's talk about CRPS and some of the nomenclature so that everybody's on, a good footing when we're referring to some of this stuff. So, complex regional pain syndrome 1 versus 2. New nomenclature. So go ahead and tell the audience a little bit about that.
So, type 1 is there's no injury to the nerve. And then you have type 2, which is causalgia, which is nerve injury. And so what CRPS really is excessive pain and inflammation syndrome that usually typically follows some type of injury. I think you want to be in the type 2 category so that you're able to define what's causing the CRPS and then try to alleviate that versus being in the type 1 category where you've really got nothing to work off of. And so if you've got chronic regional pain syndrome and there's no real cause, well, now what are you really targeting? And I think that's when it kind of gets to central, we'll talk about as peripheral versus central sensitization. But this paper really talks about how inflammation, specifically neuroinflammation, is a contributor to either type of CRPS, whether you've got type 1 or type 2. But yeah, there are the two types that exist, and it's very important to delineate which type you have, because that's
I want to interrupt you there, because I think I'm going to say something a little bit controversial right now. But when you think about it, it's probably not that controversial. And that is that I think CRPS type 1 is a category for the lazy. It's a lazy diagnosis, because I really think that the majority of type 1s, it's like idiopathic neuropathy. It's idiopathic because we're all idiots and we can't figure it out. And I think it's the same thing with CRPS 1. I think CRPS 1 very definitely has specific, maybe not named nerve injuries, but branches of named nerve injuries, and that with really excellent workup and using, diagnostic lidocaine blocks, we can figure out a lot of these that were labeled as type 1, CRPS 1, are really CRPS 2, because we're able to find that injured nerve. So, people get caught up in type 1 versus type 2. I think that really when it comes down to it, I'm not going to say all, but the majority of type 1 there is a known nerve that's injured, and we can find it. I can't argue with you on that fact there, because it kind of goes back to when we talk about idiopathic neuropathy, right? Right.
It's a similar type thing, is that what's the real idiot in idiopathic neuropathy? So I can't argue with your logic there. I mean, it very well is maybe we're just not delving deep enough into finding the source.
Right.
Absolutely.
So I like this paper because it gives us a little bit of a great, I think, biochemistry primer into what's going on with CRPS. So regardless if it's 1 or 2, it's still the same process that's going on. And they break it down pretty nicely into the different tissue types that are affected. The only thing I would be critical about of this paper was that they talk about the keratinocyte last in the paper. And I think the keratinocyte should probably be talked about first. So let's kind of jump to the keratinocyte. And, for the non-physicians listening to this, the keratinocyte is just the skin cell. And for decades, it's been thought of as simply a barrier keeping us from exposed to the outside environment. But it turns out that the keratinocyte responds to both chemical and mechanical stimuli with some pretty incredible reactions from, upregulating different receptors. So let's talk about the keratinocyte first, and then and then I'm going to give the surgeons maybe a little idea of maybe what to do to address some of the keratinocyte activation at their time of surgery. So.
Sure. So when we're talking about keratinocytes, we're going to be mentioning types of neuropeptides. So I just want to, the types of neuropeptides that exist are going to be substance P, calcitonin gene-related peptide, which is CGRP, and neurokinin A. So these are the neuropeptides that are released in response to the inflammations. So what happens is when you have a peripheral nerve ending, let's say, you activate the C fibers, and then the C fibers then transmit pain signals to the dorsal root ganglion. And during that process, you're releasing the activation of C fibers leads to the release of C peptides. Or neuropeptides, and that's what leads to this whole cascade. And when we talk about keratinocytes, for example, we're saying that in patients who have CRPS, keratinocytes have been shown to highly express these neuropeptides, which is CGRP, and it can also go ahead and stimulate cytokine secretion. So when they looked at a set of mice they'll talk about in the paper. And then when substance P and CGRP were injected into these mice, the nociceptive stimuli mediated secretion of interleukin 1 beta, which is a type of pro-inflammatory cytokine, that was increased in keratinocytes. So basically what we're saying is the skin is an organ. It's the largest organ, but it's a organ of the neuroendocrine immune system. So the skin has a very close relationship with the nervous system, and the free nerve endings are coming from the skin, and the keratinocytes are crucial in sustaining neuroinflammation as the first point of contact. So that's why they're very, very important. And so when I talked about the nerve endings being stimulated, they're being stimulated in the skin, in those keratinocytes. So the skin, as you already mentioned, is going to be a very, very important aspect of this, even though they mention it last in the paper, because that's where you're going to be able to see or touch or feel mechanical or chemical stimuli, right? How do you come into contact with stimuli? It's through the skin, and that's where your nerve endings lie, and that's where this whole cascade begins.
So from a surgical standpoint, I mean, I think you could make a really strong argument that you're the first tissue type that you encounter in almost any type of surgery. I can't think of one that would fall out of this category, would be the skin cells, because you're going to make an incision through the skin. Now, the other thing we need to mention is that there are primarily it is C fibers that are stimulated, but there are some A delta fibers that get tweaked along the way. But this is something that, it makes a lot of sense to pay attention to the skin, because when you're planning a surgery, and I would recommend this for every surgery that's done to prevent or to decrease the likelihood of development of chronic postoperative pain, not even, thinking about CRPS here, but that would be just to locally anesthetize the skin in the area that you're making the incision. Because one of the things that I remember is that about 70% of the C fibers in your skin are in a dormant or a quiescent state. And so they only become activated when they have this mechanical stimuli, which would be the incision from a scalpel. So if you're able to block that keratinocyte nociception with a local anesthetic, you're now obviating one of the first tissues that play a role in the development of this neuroinflammation that subsequently becomes so complex in the whole generation of the CRPS.
Absolutely. No, I think that's a very important point that you bring up, because not a lot of, sometimes people do local anesthesia before they even start surgery. Actually, they do local anesthesia after surgery. So after the procedure is done, we always give our local anesthetics blocks for long-lasting relief, but not a lot of people do them beforehand, before they make the skin incision. So that's very, very important, because yes, technically, even though the patient, if they're under anesthesia, even though the patient can't feel the scalpel when we make a skin incision, you're still disrupting those nerve endings, and they're very much going to be leading to this neurogenic inflammatory cascade that's going to be activating all these neuropeptides, which are going to be taking signals back to the dorsal root ganglion. So that's a very, very important point, which I think why how we have our protocols set in place for when we do surgery is very important. I believe, when we did surgery together, you have a very specific protocol that you like to use for anesthesia that involves ketamine beforehand. Is that for the purposes to help with such things from happening, CRPS from happening, or a type of chronic pain situation?
Yeah, it's very definitely. So we can jump into ketamine a little bit later as far as, what its mechanism of action is. But from a perioperative standpoint, I really don't see any hurdles or negative contraindications. I mean, there are some, of course, but generally speaking, perioperative administration of ketamine, I think, is hugely important. Everybody's talking about reduction of opioids post-surgery. This definitely has shown to decrease the opioid consumption, at least in the first few days after surgery. But just its neuroprotective mechanism, it seems like the benefits far outweigh the risks. So, I mean, I can't think of a patient that I've done surgery on in the last probably 15 years that we haven't. I mean, there's one that I can recall that had a bad reaction to ketamine, but it's really very safe. Most anesthesiologists don't have a problem with it at all, and I think it's just foundational. And we know that in patients that have had long periods of preoperative chronic pain, they're much more likely to develop a chronic postoperative pain syndrome than somebody who has had a very short duration of pain. So it's kind of like the dry tinder thing. You know, you have these patients that have been really messed up and they have CRPS or they have, chronic pain. They just are a lot easier to, for a little spark of surgery to set the whole fire off because they just, they're just hot wired already, so to speak. So they make going back to the keratinocyte, which is, they make a statement in here, which I think is very apropos to what we're talking about. And they say neurogenic inflammation may start in the skin, which is usually the common site of injury. Keratinocytes are crucial in initiating and sustaining neuroinflammation, as they are the first point of contact for external stimuli or insults. Keratinocytes originating from the ectoderm can secrete various neuropeptides. And then they state that a significant proliferation of keratinocytes has been observed in the skin of patients with CRPS. Now think about that. So the keratinocytes playing a role in the genesis of this neuroinflammation that is a huge part of the CRPS. And so that the tissue that's actually promulgating this issue then hypertrophies to an extent. So it's almost like it's just the snowball rolling down the hill. So the more keratinocytes are involved, the more they get other keratinocytes involved, and it just becomes this cumulative thing. Now, this may play a role in why some of the topicals that we use, topical ketamine, for example, tends to quiet some of these folks down quite a bit. This may be, one of the reasons behind that. Absolutely.
And I think that's why that's interesting, because if the keratinocytes are proliferating, that means the more they proliferate, the more it's almost kind of like the body's
the more dose they can give you.
Right. The body's going to consistently think there's something, why is this happening? Because you're creating something outside. This is a situation that the body's creating that's outside the norm. So you're dysregulating the equilibrium. And so that's how you lead to this chronic neuroinflammatory state, in a sense, is because these keratinocytes are upregulated and they're more than the normal amount. And so the body's constantly going to think there's something wrong here, and it's going to release these neuropeptides, and this inflammatory cascade is just going to keep progressing.
Yeah. So I think then that leads into the next tissue type that I would go to, because we know now that the keratinocyte can release these neuropeptides, which then can stimulate glial cells. And that plays a role in both peripheral sensitization as well as central sensitization. And so if we talk about glial cells, it's been a long time since I've talked about glial cells, so it's great to have this refresher. But then they, in and of themselves, interact with the neurons, immune cells in those areas, blood vessels in the area, and then all these components then kind of take up the expression to further this neurogenic inflammation. And that can then create a lot of the peripheral and central sensitization that we see in these patients. So I guess the thing to remember. Go ahead.
Yeah, I was going to say the point that they make here is that previously, the previous classification of microglia was that there are two phenotypes, that there's the M1 pro-inflammatory and then the M2, which are anti-inflammatory. So they're saying you got two types of microglia, but this paper is saying it's evident that this categorization fails to capture the actual physiology of those cells, because now if we put neuropeptides and neurotransmitters can activate these microglial cells, right, from a non-activated to an activated state, then it's so much more complex than you got two types of microglials, because it's not about the glial cells themselves, it's about how they're interacting with the other neuropeptides and how that complex in itself relays information back to the dorsal root ganglion, eventually the brain, that can lead to central sensitization. So that's a very interesting point they make there.
Yeah, to further that point, they also state here what they say is autopsies of patients with long-term CRPS have revealed that activation of microglia and astrocytes was predominantly at the level of the initial injury, but extended throughout the spinal cord. So just like they saw an increased amount of keratinocytes, they now have seen increased amounts of microglia deposited in the spinal cord of that segment where that injury occurred. So these are pretty, good morphological examples of what has led to them from a biochemical standpoint.
Absolutely. Yeah. And so that's very important, is, when you're talking about the site of injury, how does something extend beyond that? It's through these cells, right? Because they communicate beyond. How do they communicate beyond? Is through these inflammatory cascades. So it's these cells, such as the glial cells, that eventually relay the signal, through the spinal cord, eventually back up to the brain. And so that's why, it's very important. These cells are extremely important in doing that, because the injury, if it happens in the periphery, they are going to be what takes it to the central aspect. Yeah.
And then here's something that I didn't know, but I find incredibly interesting. So we start with the keratinocyte, presumably. It fires up. It triggers some reaction because it generates these cool little neuropeptides that aren't so cool if you're having pain, but they then stimulate the glial cells to activate, both the microglia and the astrocytes. But then they point out that astrocytes can then establish gap junctions with neurons, and then that allows the glial cells to actually modulate neuronal activity directly. So it's now like you've taken the skin cell, you've injured it, it produces all these neuropeptides that upregulate these glial cells, and now these glial cells have the fertilizer, so to speak, to grow a connection to the neuron itself. So you have this pretty incredible biomechanical and cellular process going on to reestablish something that wasn't even supposed to be there. So that changed the whole phenotype of this peripheral nerve or central nervous system axon neuron. So it's pretty sophisticated. It's kind of like those examples of all the dominoes stacked on top of the table. The first domino would be your keratinocyte. You tap that, and then it goes and then all of a sudden, all the dominoes fall. And eventually you activate enough of those dominoes, and they talk about neuronal plasticity. Right. And just like you mentioned, now you're, because, we always talk about the concept of plasticity of, we talk about it in a positive aspect, but here we're talking about it in a negative aspect is that now you're creating new synaptic pathways, but for the wrong reasons. These cells are doing it to generate consistent chronic pain. So, so it's a pretty complex process. And I don't think there's any doubt that neuroinflammation that gets out of control plays a huge role in the development of CRPS. I think there also a lot of indication that there are certain folks that are genetically predisposed, maybe. And, more and more of that work is starting to come out. But just understanding the concept of the neuroinflammation and how it plays a role in these negative upregulations and the subsequent development of CRPS are pretty complex. So let's talk about the Budapest criteria for a moment, because there are a lot of practitioners that see CRPS. And I don't want to say routinely, because it is pretty, thank God, it's pretty rare, but it's not rare enough that we don't see it, especially in a tertiary specialty nerve clinic. But the question is, well, how do you diagnose it? Because CRPS, a lot of times, I mean, you've seen this when you were hanging out with us. One day they're pretty good, and then the next day they're pretty bad. It looks like, one day their foot just came out of the boiling water, and the next day it looks like it's cooled down a little bit, or next visit. So these things can fluctuate a little bit. So let's talk about the Budapest criteria. It was developed by the IASP, the International Association for the Study of Pain. And it's based into two components. One is a subjective component that's related to what the patient tells you. Do they have some disturbance in their sensory? Hyperesthesia, they're usually allodynic. Vasomotor, do they notice any temperature changes, any skin changes? Pseudomotor, which would be, swelling or excessive sweating or lack of sweating. Sometimes they'll become xerotic and just dry. And then motor or trophic changes, like do they have changes in their nails? Have they lost their hair? Did they grow more hair? These types of things. Do they have a decreased range of motion? So in order for them to meet the first part, they have to have a positive sign in one of those four boxes 3 times. So they have to be positive in 3 out of the 4. So if they meet that criteria, and then your clinical exam is where the second part of the Budapest criteria comes into play. Again, you're looking at sensory, vasomotor, pseudomotor, and motor trophic. And basically what you're motor or trophic, basically what you're looking at here is a clinical validation of what the patient just told you. So, and that one, they have to have at least one sign in 2 or more of those categories. But if they meet that, then by the Budapest criteria definition, you can make a diagnosis that they have CRPS. It doesn't tell you that it's CRPS 1 or CRPS 2, but as we talked about previously, that probably doesn't really matter unless you're really trying to diagnose where you're going with, your nerve mapping and that type of thing to try to figure out if you can get rid of that temporal pain generator that's really leading to the whole thing. So, before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000. But you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been.
Right. Yeah, and we talk about this, but if we go through, let's just say, a sample case study, if you get a patient who presents to your office, what does that look like clinically? Because some of these patients are going to be more subtle, some are going to be, you can tell, because this diagnosis can often be thrown around. So when a patient presents to your office with some of these criteria, one of the more severe cases that I've seen recently, I'm seeing a patient and he's, he had foot surgery done, And when he originally presented, he hadn't seen anybody for it, but he presented in a wheelchair. He can move his left leg completely fine, but he won't move his right leg. And so that was the first thing that you noticed about him was he can move it. He's got motor strength. There's no muscle weakness there. He's afraid to move it because he's scared it's going to cause him pain. Right. He won't even put his foot on the ground, right? And so that's a very severe form of the motor/trophic aspect of motor dysfunction, even though it exists. You've made a connection to your brain that I don't want to move it because that movement is attributed to pain. Right. And then the other thing that was very prevalent in a patient like that is when I had him stand, you could see the color difference in one leg versus the other. Sometimes when patients present to the office, you might not see the color difference right away. It's something that they may show you pictures of or something they mention. Oh yeah, I think my foot changes color. But how do you verify that, right? And so sometimes in some patients it's severe enough you could see it in the office. And it's more of a violaceous color. And it's very, very distinct. There's your temperature asymmetry, your skin color changes. And then, of course, edema or sweating. Some patients will have just a very swollen foot, or some of them will just tell you, yeah, I feel like my foot swells or my foot sweats all the time. There may not be edema associated with it. And then, of course, one of the main ones that we mentioned was sensory. And there's a variety of ways to test for allodynia because I think the patient that I'm talking about was afraid to put his foot on the ground, not just because of pain too, but because he was just that hypersensitive. Right. Just a light touch to the floor. He was scared that was going to elicit pain when normally touching the floor, that's what we do all the time. That shouldn't be causing any pain. So another way you can measure for it, sometimes people will use alcohol swabs.
Mm-hmm.
Or acetone. Does this hurt? Acetone, yeah.
Right.
Yeah, the acetone test, you could put it in a small amount, use like a 5 cc syringe, and you could test one leg versus the other. And right. if one can cause pain, well, that shouldn't be the case.
Right.
And so there's various ways to do this, but it's very important to make sure that whatever they're talking about falls under some of this criteria, because you'll get patients a lot that will tell you they have a diagnosis of CRPS and, my doctor told me, nobody can really touch this foot because I have CRPS. But I feel that now if you haven't properly gone through the avenues and diagnosed the patient properly, now they're at a higher alert in general when really they have no other issue going on. So it's very important that you look at this criteria and you do the proper testing in clinic compared to just what the patient is saying, because then it's always constantly going to be in their head and they're going to not want to let you treat them based on what they're told. Right.
And I think, this brings to mind a case that I remember, it's probably 10, 12 years ago, but these cases of CRPS, just like anything else, I think that there can be exacerbating comorbidities. And I think that patients who are maybe not as ideal metabolically, maybe more predisposed or, more likely to maybe develop a chronic pain or CRPS. But there's this one patient that I recall that she had wicked CRPS. Actually, she had it, as I recall, in one hand and one foot. And I forget what initially caused it, but we did everything we possibly could. She had neurology consults. She was in with pain management, was doing all of the things, physical therapy. And I don't know how it came about, but she discovered that she had a gluten sensitivity. So she went on a complete 100%, like very rigorous diet with no gluten exposure whatsoever, and came back in about, a month, and almost 100% of her symptoms were gone. And it's like, well, that's great. Just keep doing what you're doing. So there was no doubt that she had CRPS, but it seemed like this comorbidity, her gluten sensitivity, just added on to that. And when she was able to take that away, then her symptoms, if not completely gone, were gone to such an extent that she had almost a normal life again. Then about 4 or 5 months later, I saw her again, and she's had a flare up, and then discovered that there was actually some gluten in what she had eaten. It wasn't like she was going off the gluten-free diet, and that gluten exposure, just that one thing, fired her up big time.
Wow.
And so I think, that gives you some impetus to think about these patients in, more of a global situation. It's like, what's going on with them from, we know that there's a lot of immunology taking place in this constellation of neurogenic inflammation. But is there something else going on with these patients that we can manage, like a gluten sensitivity or like, really bad insulin resistance? And these are things that's why I think you have to look at the whole patient, not just that symptom complex. But that was a great case because it illustrated how these exogenous things can exacerbate or, just create a big problem. And by eliminating them, then all of a sudden it became much more manageable.
Right. Yeah. And that's a very good point that you bring up because, thus far we've been talking about exogenous stimuli. So here's an example of an endogenous stimuli.
Right.
So that's really interesting to know because obviously I'm still fairly new. I have yet to. I always see the type of patients that have had some type of external injury, but that's always something good to keep in the back of your mind. Is this something metabolic, which we always tend to overlook? Is this a side effect of something they're already on?
Well, I want to be very clear to the audience. I'm not saying that. I mean, this lady did have a traumatic insult that led to her development of the chronic pain, but it was the gluten that was really firing this thing up. So those are the things.
So the gluten made it worse.
Oh yeah, for sure. But she definitely had a traumatic result, and I just can't remember exactly what it was. But I thought that was an interesting. Sometimes these patients will teach you a lot. In the same vein, and I haven't really had any experience with this, but conceptually, for some of these people and it may be a really difficult thing to do, but maybe a 3 or 5 day fast, properly managed, could really decrease a lot of their inflammation.
Yeah. And so it kind of goes back into this, chronic. You're in this chronic inflammatory state. So if you're in a chronic inflammatory state, now you're kind of going into a fasting state with your body. Is that, you think, probably going to be down-regulating some of these cells to, because we don't know what could be making this worse, you're completely stopping everything so that these cells don't have a chance to feed off of that stimulus that could be making it worse. And in a sense, you're changing the plasticity of events, I guess.
Right.
Because we talked about neuronal plasticity, and if your body's so used to something, then this is the kind of the way of just resetting it completely.
Yeah, and I think there's no argument that sugar is a highly inflammatory molecule, and that, in a fasting situation, you're really decreasing that carbohydrate load. So maybe there's just less inflammatory material circulating around in the systemic circulation. Right. But yeah, I think that that's something. I know there's been tremendously dramatic cases reported that, in cases of RA where people were virtually crippled with their arthritis after a 30-day fast. And a lot of this stuff comes out of Eastern Europe and the former Soviet bloc countries. But after 30 days, with well-managed fasting, they had no arthritic pain, no swollen joints. It's pretty incredible. So that may be another avenue to think about when you have a patient with, complex regional pain syndrome, is that maybe there are some other things that are going on that could be pretty easily managed or more easily managed by just trying to optimize the patient. But it's hard to tell somebody don't eat, and then fasting, right? And fasting is a science in and of itself. And there's ways, if you follow the right protocol, you can do it. Have you ever fasted?
I've done intermittent fasting,
right?
But I haven't fasted of my own accord. No, it's probably happened because maybe I'm doing something and something is being preoccupied, but I don't think to just do it for any specific reason. No.
It's a difficult thing. I mean, the most I've done is 48 hours.
Oh, wow.
But
that's the most. I don't think I've ever done that in my life. Yeah.
But it's kind of funny because you go through this, like, where you're really hangry, and then all of a sudden you're not hungry at all. It's really kind of weird. And then, you notice some certain things just even in, day and a half, 2 days of fasting. But I've never had the dedication or the motivation to do like a 5-day fast. But a lot of people recommend a 5-day fast once a quarter to just kind of reset everything. So it's something we ought to maybe look into. I think the fasting thing's kind of an interesting thing. Yeah.
Well, these days everybody also talks about you could do fasting, but what about just doing a colon cleanse? But I guess you're still not eliminating that aspect of eating.
Well, I think you could do the colon cleanse and the fasting. And if you use coffee for your coffee enema, just don't put any sweetener in it and you're good to go, right?
There we go.
Yeah.
You got everything covered. Absolutely.
Yeah. Well, the biohackers can teach you all this, But,
I've got an interesting question for you. So, we've been talking about this, but do you think there's varying levels? So we say you either have it or you don't, or do you think there's some kind of spectrum to it? You've got a chronic regional pain, like there's chronic, we always say you have full-blown CRPS, or is there more, some things that's of that level, but it's not completely, what if you're meeting some of the criteria, but it's not enough to say it's CRPS? Well, then it's not CRPS then, or do you think there's a spectrum?
No, I think there's a spectrum, and in my clinical experience, I've seen patients who have come to me and they've said, I had a CRPS outbreak, and they were able to show you pictures of the vaso spastic changes they clearly had at one time, and then they went years without having really much symptoms or anything like that. And then you operate on them and it fires right back up again. So there's no doubt. Yeah, I don't think there's any doubt about varying degrees of symptomatology in CRPS. I think some people are just super unfortunate and they're just afflicted, just massively afflicted, and there's really not much that can be done. I mean, I have a patient right now that basically can't even get out of bed and is wrapped up in all kinds of furry blankets, and it's a devastating presentation. And then there are other people like the lady that I was talking about with the gluten sensitivity, no gluten, no symptoms, and so there's definitely a spectrum. And I think that's something that, when a patient presents to you with CRPS, is that they're usually of the mind that there is no hope, that, they read all of this stuff on the internet and they're doomed. And the answer is the body is miraculous, and, miracles do happen, and people will have cessation of symptoms even with CRPS. And so it's not this linear thing at all. I mean, that can go along with no symptoms and then off the charts and then get it controlled back down to normal. And we see this within patients all the time. They'll come in and it's like, I'm doing pretty good this week. And, last month I had kind of an outbreak, and, different things can trigger these things. But to answer your question, I definitely believe at least in my clinical experience, that there are different levels of severity with CRPS.
Right. So I guess, is it safe to say that, can you fully cure it? Because if it keeps coming, if it wanes in and out, then it's how well you can maintain, how well you can keep it calm, I guess. Right. Or is there there's no actual way to say, oh, you're fully relieved of your CRPS. That's it. You won't need anything further. It can always come back. And
you have to be real careful with the C word, right? Cure is a tough word, and you got to be real careful with that. But I think you can safely say that we have a great chance to improve your condition, ameliorate a large majority of your symptoms. I think those are legitimate things that can be done. We could come back and talk about different types of intervention. Maybe that's what we should do in a subsequent talk, because there are a lot of things that can be done that aren't really being done now. Things like hyperbaric treatments, ketamine infusions, ozone therapy. There's a lot that can be done. We should maybe look into that and have another chat on that.
Absolutely. Because I always get to learn a lot too. When, every time it's always a great learning process. You get to delve back into some of these issues, and you get to question yourself too, because the research is always getting updated, and sometimes we're still in the old mindset of what can be done for this, and not in the newer mindset. And so it's always great to have these talks and to discuss it. But no, that definitely makes sense. When we were talking about the symptoms can come back, it's always very interesting what patients will say. Sometimes even the smallest things, maybe using a nail cutter, to cut your fingertips, can bring it back. And I'm always still amazed that, are you sure nothing else happened? That's what caused it.
Right.
So.
Yeah, no, for sure. Yeah. And sometimes it can be, a paper cut, and they develop CRPS. And then other times you can have a pallet fall on and crush their lower leg, and they don't develop anything but maybe, some chronic pain in the scar or that type of thing. So CRPS is so complex, and there's so many things going on. That's why I like this article, because I thought it broke down a lot of the interplay from the neuropeptide expression, the different types of tissues, how the keratinocytes are interacting with the glial cells. And, I just thought it was a great article for somebody that is maybe not really taking the time to put their head down over an article and look at, hey, what is the most recent stuff? So, I think that, hopefully they will develop, maybe some specific abilities to knock out some of these things that, create or allow the nociception to continue. But right now, I think we're on the horizon. I think that stuff's on the horizon. I think there'll be more breakthroughs, but it's still, regardless, it's one of the worst things you can see in your practice. And I think that leads into another discussion that there's a lot of surgeons that still feel like if one of their patients develops CRPS after surgery, that they've done something wrong. And the answer is no. It can happen with any surgery, with any surgeon. It's just something that, is outside of your control. I think where you do have control is trying not to ignore it. And so when that patient comes in, 3 weeks post-op and they have some color changes, well, now's the time to really address it, maybe get some other referrals and, hit this thing from a different approach. That's going to give the patient the best chance too, rather than just doing the ostrich thing and burying your head in the sand.
Absolutely. Yeah. It's a team approach. Right. It's definitely a team approach, and you need a full team to help you with it, whether that's from the neurology team, whether that's from, orthopedic
pain
spinal
management,
team, pain management. Yeah. It's definitely a team approach. That's not something you can solve by yourself.
Right. And so you've heard the expression, when the ship is sinking, load the boat.
I have heard a lot of first expressions from you. So I have heard it from you today. Yes.
Yeah. So when the ship is sinking, load the boat, meaning, you got this complex problem, get neurology, get pain management, get whoever else you possibly can get to try to help you on this to keep that ship from sinking. So, but
absolutely.
No. Well, this was a great discussion.
And therapy.
I think this was a great discussion. I learned some stuff, and let's do another one on maybe potential treatments for CRPS.
Yeah,
that'd be good.
Oh, absolutely. I always get to learn a lot, and I hope I'm always so excited for the audience because I hope they get to learn as much as we did when we do these. So, and they're very good clinically too, because sometimes. A lot of time young physicians get confused as to how to recognize something. So that's always good.
Well, there's a big abyss between all the knowledge that you guys have when you come out of your residency and fellowship and then actually getting in the treatment room with the patient. It's like, oh, I got all this stuff, but it's not so easy to get across that bridge to making the accurate diagnosis and then, making a substantive treatment plan. So it's not easy.
Absolutely.
I wished I could draw the algorithm out, but humans don't fit into the algorithm so well, as you know. So especially in nerve. But
oh yes, nerve is very complex. Very complex
and fickle, super fickle.
Yes.
So, but anyhow, well, thanks so much. Thank you so much, Dr. Nagra, for not only coming on today, but for being my fellow. I really appreciate it. It was a great year plus, and I can't believe how fast it went by. Yes,
I'm still. You're still going to be my mentor forever and always. So, but I had a great time. I'm still continuing to always learn from you. I was just saying, I was trying to make a small joke that nerve is complex, but nothing a little bit of fasting won't cure. But,
exactly. Right.
But no, I had a fantastic time, and the types of patients that I saw in clinic were very different from what I've seen in my previous training, and what I learned the most is it's not that sometimes you lack the knowledge; it's acquiring new knowledge and how you're applying it. And nerve, because nerve is complex, it seems easy to read about a diagnosis and a nerve diagnosis, but how do you actually come to recognize the signs, symptoms, and then how do you confirm your diagnosis? And then how do you come up with a plan? It seems that, this is something I've already learned, it should be easy, but it's not until you see these types of complex people in chronic pain that you realize it's a lot much more to it. So I had a fantastic experience learning that.
Well, in this arena, you never stop learning. Because you just can't. So, well, have a great weekend. Thank you so much for sharing this with us, and can't wait to the next one.
Yes, always a pleasure. Can't wait.
Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardio protection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pot of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pot of Inquiry. Use Pod of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to approved medical solutions, you can give them the best care without the worry of oxalates.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only. It does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is the responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.